So I'm going to begin by introducing a family support group called SOFT, which is dedicated to individuals with trisomy 13, trisomy 18, and related disorders. Once upon a time, it was early 2020, and I heard that the SOFT annual family conference would be held in Roanoke with featured speaker Dr. John Carey. So I said to myself, well, we must invite Dr. Carey to give grand rounds while he's here in the Star City of the South. And, oh well. But anyway, I'm delighted that Dr. Carey agreed to give this talk a year later. Dr. Carey has had a long and productive medical career. He received his medical degree from Georgetown University. He subsequently completed his pediatrics and medical genetics training at the University of California, San Francisco. He has a master's of public health from the University of California at Berkeley. Subsequently, he moved to the University of Utah. He has held multiple leadership roles in patient care and medical education. He's currently the Emeritus Professor with the Department of Pediatrics at the University of Utah School of Medicine. His research focus is the study of human congenital malformations and their causes. He has authored or co-authored over 300 papers, chapters, and editorials for scientific journals. He served 15 years as the editor-in-chief of the prestigious American Journal of Medical Genetics. He co-authored the Geordie, Carey, and Bamshad textbook of medical genetics, and he co-edited Cassidy and Allinson's Management of Genetic Syndromes. Dr. Carey has served as the medical advisor and founding professional for the SOFT support group since 1980, and he's particularly interested in the medical and ethical aspects of care for these patients. So live from Utah, please welcome Dr. Carey.
Good morning and thank you. Just wanted to say at the beginning that I have no disclosures, but in the spirit of forthrightness, I am the medical advisor for the support organization for trisomy 18 and 13, and I also serve on their actual governing board of the organization. But I have no commercial disclosures of any kind. So I appreciate this opportunity to present my now favorite topic. It is in conjunction with the fact that we are having a virtual conference of the support organization for trisomy 18, 13, and related disorders. And during this week, there's a series of 10 family conferences, and there are 5 medical seminars that professionals can also join and participate in at no cost. So I'm really happy that I'm able to do this here, in at least virtually for you in Roanoke, because we were going to have the SOFT meeting there last year. Couldn't, of course. We were going to have it this year. We can't. Hopefully, we will have it next year in Roanoke, and we'll be there in person. And I welcome anyone to participate in the conference next year. So here is the purpose of my talk. I'd like to identify the important themes in the care and management of a child with trisomy 13 and 18. It's probably most of you know, the management and care has some controversy surrounding that, and I hope to actually identify some of the themes and issues that kind of overlie that controversy. My second purpose is to provide you with a concise summary of the phenotypes. It will be concise. Talk about the survival studies, because numbers, figures, because I think we need to know that in counseling families prenatally and postnatally, and then discuss some of what we know about the developmental outcome of children with these 2 important syndromes. So the objectives, or after this presentation, I'm hoping that you will be able to list the important and distinctive manifestations of the 2 trisomy syndromes, summarize what is known about the outcome, in particular survival and development, and identify the key issues surrounding why there might even be a controversy in care here as we go along. So I do have a kind of unique connection with these conditions, besides being a medical geneticist and a pediatrician that's cared for children with complex disorders and rare conditions. The SOFT group was established in Utah in 1979. They incorporated, if you will, not incorporated, but got their contract and all of their bylaws in 1980. And I've been the medical advisor for that group, as I mentioned, since that time. So I have seen many older children with trisomy 18, 13 and related disorders like trisomy 9. This is kind of the little small poster that SOFT has that we give at medical conferences and other forums. And I know all the children in this picture that I've met at conferences over the years. So working with these families of the children who do survive or who live for a while and then they still participate in the conference has given me a perspective, I think, that's different than at least most geneticists. So here's the outline of my talk. I'm gonna give you more on the background, discuss some premises, then I'm going to pose 3 timely questions, and then attempt to answer those questions by discussing what we know about the natural history of both syndromes. And I'm going to close with just some comments about discussing with families regarding goals of care and shared decision making. I've embedded 3 questions during the talk, and I'll pose those questions at certain times. They're placed about, in about a third of the way through, about half of the way through, and so on. And then I believe you can actually answer those questions in the chat, and I'll provide the answer. So my background is about this issue that there is some controversy, some discourse, as opposed to now caring Down syndrome and other syndromes. There's some conventional wisdom that surrounds the conditions, I think, that are different. As you likely know, the conventional approach is to apply non-intervention, if you will, and pure comfort care. And pure comfort care in this decade and the last decade is actually compassionate care by palliative care teams or by other supportive individuals. And actually, comfort care is an active process. But in terms of technological interventions and ventilators and even cardiac surgery, the wisdom has been to have more of a non-interventionist approach. And this is throughout the literature. But as you'll see, there has been some shift in that paradigm. From around 2006, and even ongoing now, even ongoing this month, there has been in the medical and mostly pediatric and even prenatal and bioethics issue, an emerging dialogue that's kind of made this conventional wisdom more discussable, as we will go over in the next 50 minutes or so. One of my neonatal colleagues says that around decision making, often in the nursery, sometimes even in the fetal center, there's kind of a palpable tension. That's because trisomy 18 and 13 are very complex conditions that are medically serious, and I'll outline that in a few moments. But part of this emerging dialogue is a paper that appeared in 2008 in Pediatrics by Dr. McGraw and Perlman, 2 neonatologists who polled neonatologists in the state of New York, and they were given a case of prenatal diagnosis of trisomy 18. The fetus also had a ventricular septal defect, and they were asked the question, if the baby had difficulty breathing in the delivery room, would you resuscitate? So 56% of them said that they would not resuscitate in the DR. They didn't have anything that said they would discuss it with the family, but they said that they would not resuscitate. And we know what people say in surveys may not really be what they actually do. This is one of about 5 similar survey studies that have appeared since 2008 that all have somewhat similar results. That the majority of perinatologists and neonatologists feel that the non-interventional approach is the way to go. At the time, Dr. Scott Showalter from Denver was the father of a child with trisomy 18 who passed away when he was a few months old. And separately, myself wrote letters to Pediatrics, which were published a few months later, that had to do with the challenge of actually defining the best interest standard. And that, in fact, is what McGraw and Perlman were saying, that the pendulum had swung far toward parent autonomy in these decisions, and we need to be thinking about best interest. I'll talk more about that paper a little bit later. In 2012, I was invited to write a review for Current Opinion in Pediatrics, Perspectives on Care and Management. This is the topic of today, and I refer you to that paper where most of the issues I talk about, not the recent papers, are brought out in that paper, which was, then also entitled Striving for Balance. Also in line of this sort of background about why there's a discourse here. There was a seminal paper also in Pediatrics, also in 2012, where Dr. Janvier and her colleagues polled over 300 families through social networks about what the experience was of rearing or having or even losing an infant with trisomy 13 or 18, infant or child. And generally, while they recognize as the challenge, they actually talked about some of the joy that occurred in the care, and that they almost to a person felt that their child, despite the challenges, lived a happy life or had lived a happy life. Also in this line, another what I would consider a key paper. Again, I'm going to discuss this in more detail toward the end by Lorenz and Harthart, also in Current Opinion in Pediatrics, that did really, I think, one of the best jobs in kind of laying out a plan of how we might talk to families within some of these complex decisions. And lastly, in the way of this background, I draw your attention to Dr. McCaffrey's paper. He's down a little south of you in University of North Carolina, neonatologist, where he actually drew a parallel between some of the discourse in trisomy 13 and 18 and some of the controversy is similar to actually what was occurring in Down syndrome in the 1970s, time when I was a pediatric resident, where it was actually common to offer a family no surgery when there was duodenal atresia. And then, of course, in the 70s and 80s, for a number of reasons, which we're not going to have time to talk about, that obviously changed. He wrote, posed the question, is there a change in the paradigm? So let me pose you three questions that I originally posed in that paper in Current Opinion, and then I'll try to address what we know about, try to answer the three questions. So the first question is, are trisomy 18 and 13 uniformly lethal conditions? I put lethal in quotes because that is commonly used, even more, let's say, in the perinatal scenario, but it is commonly used. Incompatible with life is another term commonly used. Second question, what is the neurodevelopmental outcome? We don't have a lot of actual data, but I'll show you what we have. And then I'll again keep discussing this idea of why there is even a controversy. But by the way, I will work on leaving some time at the end. So if I speed through the last few slides, we'll do that. So let me spend most of the rest of the talk discussing the natural history, what we know about the survival and mortality figures in population studies, neurodevelopmental outcome, and some other medical aspects. So as probably everyone who's attending knows, these conditions are very medically serious. They're associated with an increased predisposition to medically important congenital malformations, especially of the heart. 80% of children with trisomy 13 have a heart defect. Over 90% of trisomy 18 babies have a congenital heart malformation. There is a high increased neonatal and infant mortality. And I'm going to share with you a summary of the population studies because I think they're important in being able to talk about this in counseling families. And then of course, there is the neurodevelopmental outcome, which involves a rather serious and significant psychomotor and developmental disability, which we'll also talk about in more detail. And primarily, this mortality issues and the morbidity issues are what bring up issues to discuss quality of life in any care conference that we would be involved in. So trisomy 18, I meant to mention that the overall frequency of trisomy 18 and 13 together, that includes stillborns and terminations of pregnancy and liveborns together, is 1 in 1,800. So that's actually a quite high figure, higher than spina bifida, higher than many other genetic conditions you're familiar with. But we're going to be focusing today almost exclusively on the little bit less than half of that number, that is the live-born babies with trisomy 18 and 13. So trisomy 18, also known as Edwards syndrome, is the second most common autosomal trisomy after Down syndrome. The live-born prevalence is best estimated at about 1 in 6,000 live-borns. You can see the range there. And as mentioned, this is a recognizable pattern that involves the anomalies, the survival figures that we we're going to talk about, and psychomotor disability. The phenotype is quite consistent. Babies are usually SGA. They have typical facial features, but they're not as distinctive as trisomy 13 or even Down syndrome. Characteristic hand posture, which often is a help in making the diagnosis in the newborn nursery. Short sternum, also a consistent feature. And then of course, the medically significant malformations. Here is a picture from Lancet of Sarah. Sarah was the first patient we know of with trisomy 18. We know, of course, that it existed before that. She was described in a paper in Lancet in April of 1960 by Dr. John Edwards, who was called to see her on consultation. He had read the paper on Down syndrome being due to trisomy 21 only a few months before. So he thought maybe with this organized pattern of findings that she had, maybe it was on a chromosomal basis. He took a blood sample, went back to Oxford with his cell biologists before we had cytogenetics as we have now, and actually found there was an extra chromosome in what we then called the E group, trisomy E, or now we know trisomy 18. You can see that Sarah has the overriding fingers there. That's quite typical, that I'll show you in a little more detail in a moment. I know her name because Dr. Edwards came to a SOFT conference in 1990, and this is Dr. Edwards and his wife, who's on his right, and that down there is Kyle. He actually lives close by to you in Delaware. He's now 31. He has trisomy 18 mosaicism. Dr. Edwards passed away a few years ago, but he shared Sarah's story with me, and that's why I know her first name. SOFT was formed, as I mentioned, in 1979 and 80 by two mothers, and these are their daughters in the upper right panel. That's Carey and Rachel. By the way, these families celebrate that I use their child's first name, or recognize that, just so you know that I do have their permission to state their names. And the picture of the two girls up on our upper right panel was in the home of Chris Holliday, the mother that founded SOFT back, as I mentioned, in 1979-80. And I was the geneticist working with Carey, and then eventually with Rachel as well. The young lady in the panel at the bottom is a family that I met from SOFT, and they lent me this picture of their daughter, who actually passed away a few weeks after this picture. And her picture is actually in Jordy's textbook of medical genetics. And you can see that she has that overriding configuration or contour, posture, if you will. And there's the picture there in the right of a young, actually premature baby. And you can see the overriding of the second onto the third and the fifth onto the fourth, where it's associated with a contractures of the fingers, and seen in very few syndromes. So that's why it's important in the context often of making a clinical diagnosis of and doing the karyotype, of course. And the upper panel is a boy, you can see, who has 3 18s, 3 freestanding chromosome 18s, full trisomy 18. List of malformations. I'm not going to go through them in detail. This is a concise presentation of the phenotype, so we can all be kind of on the same platform. I've mentioned about the heart defects because of the contractures of the fingers, often accompanied by clubbed feet. Some babies will be labeled arthrogryposis. About 1 in 20 children will have spina bifida. And there you can see some of the other congenital defects that occur more commonly with frequencies ordinarily at about 5 to 10%. It is often, though, the other medical conditions, the respiratory difficulties of both the upper and lower, the central apnea that occurs in so many children, the feeding difficulties. Usually in an older child, G tubes are placed 6, 7, 8 months, sometimes earlier. The high frequency of reflux leading potentially to aspiration. All of these are ongoing chronic disease issues. Most of the children, older infants and children with trisomy 18 that are followed here at our children's hospital that come from even the adjoining states are usually cared for in our complex care clinic, often an early part of their life involving the palliative care teams. But this is what's at the core, if you will, of even the neonatal and infant mortality, which summarized on this slide. The cause of death is actually complex in the half of babies who die in the first week of life. Central apnea, as I mentioned, probably not as common as we thought, because I think a lot of upper airway issues, including glossoptosis and tracheomalacia, might not have been detected in the past. But now, if we do more comprehensive airway evaluations in the family that wants to pursue intervention, we find that upper airway obstruction probably more common even than central apnea. But I would like to discuss these population studies, as I mentioned. But let me pose this question first. This is question 1 of the 3. What is the approximate 1-week survival in newborns with trisomy 18 or trisomy 13, based on the population studies that have appeared in recent decades? So 10%, 30%, 50%, or 70%. So those, I think now, I guess, from what Emily said, those now you can put your answer in the chat box. And as I think I slipped and gave the answer a moment ago, I did say it. You were right, Emily. I did actually mention it by accident, not remembering I was then going to pose the question. So 50% of children from the population studies, on average, have died before a week of age. And here's kind of a summary of those studies. Between 1985 and 1994, and then after that, from 01 to 15, there were 10 studies in different parts of the world, including the US, Europe, Australia. And the figures are quite consistent, but I'm going to point out that there were 2 recent studies in 2016 that showed higher survival. It's also important for me to mention that these studies I'm talking about here are epidemiological, population, geographic region based, with a defined denominator, a well-characterized numerator over the period of time. So I think they provide a relatively good prediction of risk of death compared to a single institution study. This is kind of a summary of those studies. 1-week survival averaged 50%, with a range that you can see there. 1 month survival was about 30%. 6 months survival was about, in these studies, about 10%, sometimes a little higher. 1 year survival would range from 2 to 8, with the average being 6%. And so 94% of children then usually would not have reached their first birthday on average. But also know that median, that is the middle child in all of these studies, whatever the N was, the median ranged from 4 to 14 days. And I want to emphasize that the few studies, because there are fewer work in trisomy 13, but the numbers are quite consistent and quite similar. But in 2016, there was a paper by Robert Meyer, also down at UNC, who put together a multi-state investigation of a fairly large N, over 1,000 infants with trisomy 18 live-born, and over 600 with trisomy 13. And they showed that the 1 year survival was actually about double of that 6% figure. So in 13, it was 11.5%, and in trisomy 18, it was 13.4%. Also interesting in that study was that they went out for the first time really and looked at 5 year survival. And you can see that almost 90% of infants who survived to 1 year, extrapolating from those that were 5 to lived till 5 years of age. Another paper appeared in the summer of 2016 in JAMA that looked at a similar question in Ontario. The numbers were not as high. There were a few hundred trisomy 13 and over 300 trisomy 18, not as high as the Meyer study, but their numbers were remarkably similar. The number of trisomy 18 was 12% as before. Trisomy 13 was actually higher at 17%. So these figures indicated that this was different than the previous population studies, and they had much higher N's than the previous work. Both of them asked the question, both studies, both authors asked the question, was the increased intervention was the increased survival due to the fact that we knew from studies done during that decade that there was increased hospitalization, increased tracheostomy, even increased G-tubes than in the past. So the question was, what was the intervention the basis for the survival figures? So the answer to the question of 18 and 13 being uniformly lethal is that even the 6% figures would say they weren't uniformly, but the more recent studies would say, no, their conditions are not uniformly lethal, but of course there is a high neonatal and infant mortality. Talk a little bit more about some of the medical issues, and then I'll go to the developmental issues. But as we do that, I want to mention a seminal study that appeared in 2006, which I believe launched this dialogue and maybe was kind of the first step in answering the question, well, is there a shift in the paradigm, based on these increased hospitalizations and maybe change in mortality figures? So Dr. Kosho in Nagano Children's in Japan evaluated 24 patients. He's a neonatologist and a medical geneticist, and he offered the Japanese families at his hospital full intervention. He was not able to offer them cardiac surgery except for ligation of a patent ductus, because there wasn't a cardiac surgeon there who was actually doing cardiac surgery at that particular time. Now there is. And at that time, in this 2006, these families, patients were seen obviously years before that. The median survival, rather than being single digits, was 152 days, and 6 of 24 of them survived with intervention, including ventilation, being in the hospital for weeks or months at a time, and in some cases, tracheostomy. So that was the first study that I knew of that actually said that intervention changed those figures. I mean, it doesn't tell us very much else how the babies were doing, but it changed the survival based on small numbers. And Dr. Kosho and I wrote an editorial to accompany the Meyer paper in 2016, where we tried to lay out what we knew about the fact that there was changing survival and paralleling that increased intervention. We couldn't quite link the two, but that was a reasonable idea to propose. One of the pieces of information, which I hopefully will have some time to talk about toward the end, has been the cardiac surgery studies that have occurred, 3 major studies just in the last 3 years. So it was after that paper. So trisomy 13, the third most common autosomal syndrome. Frequency, prevalence is about half in liveborns of trisomy 18, about 1 in 12,000. Also a syndrome. These are the major components, which many of you are familiar with. Again, this is a very concise summary. About 2/3 of children will have an orofacial cleft, microphthalmia, postaxial polydactyly, probably around 70 to 80% of children will have all 3 of them, but not every child has all 3. Here was the first patient reported by Dr. Patel in Lancet in 1960. Interestingly, the paper on trisomy 13 was right after the paper on trisomy 18. So they were back-to-back, relatively short papers, single cases, but of course the single case had a proposed etiology, so you could see it being an important publication. This infant, of course, had bilateral cleft and had severe microphthalmia that would have bordered on being called anophthalmia, also had polydactyly, and he died at a few weeks of age. Here is Aaron, in this picture, about 6-7-year-old boy with trisomy 13, who I met through soft meetings over the years. He was from Chicago, and I'll show a picture of him later on. You can see Aaron can stand with his walker and gait trainer. He's not able to say anything verbally. He could feed himself. Most his overall skills would probably be less than 12 months because of his motor and expressive language, but he did have some skills like feeding himself that would be in the 2nd year of life. He always progressed, albeit quite slowly. And on this slide, there is a list of some of the more important consistent malformations. Again, I'm not going to go through this in detail. The renal malformations, the occurrence of various conditions on the spectrum of holoprosencephaly, which adds probably something, has its own dimension related to the central nervous system, holoprosencephaly. So here is the second question. What is the most distinguishing and helpful physical feature aiding in the diagnosis of trisomy 18. Low birth weight, SGA, small overfolded ears, the overlapping fingers, or ventricular septal defect. So I give you a chance, maybe if you want to put your proposed answer in the chat box. And I did show you the picture of the overriding fingers, so you can imagine that you knew that was maybe the answer to the question, but it is quite distinguishing. So let me move on and discuss more about medical aspects and share with you some pictures of older individuals with trisomy 18 and 13 whose families are quite happy that I can share their pictures and actually their stories. So this will be kind of also a focused photo essay, if you will, for a few moments. This young lady in this picture that kind of separates the first part of my talk to somewhat the second part of my talk. In the picture, she's in her 20s. She's from Sweden. And I met her because she came to soft meetings over the years. You can see her engaging smile. She actually passed away at about 30 from a pneumonia, but she wasn't able to walk unsupported. She could stand, she could sit. She wasn't able to speak, but she was quite socially engaging, was able to indicate her wants, also had skills in the second year of life, but did have a profound developmental disability. The young woman on her right shoulder there is her younger sister, who is now an orthopedic surgeon in Sweden, also used to come to the soft meetings. So still talking about natural history, can't resist showing one of my own patients here, Aaron, on the left there. He's now 11. He lives here in Utah, and I have known him since he was an infant. He has cleft lip repaired, and Aaron had a tracheostomy along the way. So of note, there are not as many reported cases that are well characterized of older persons with trisomy 18 or 13 than you would imagine. You'd think there might be more. There certainly are series of patients like these studies I've mentioned, but to actually get a sense of that child's story and medical history, there's not that many. So there have been 14 reported cases of children over the age of 10. Christy in that picture wasn't medically reported. She's now 21. Her mother is one of the leaders in SOF, one of the board members. 5 of those 15 had a skin biopsy to kind of look to see if they could have had mosaicism. None of them did. Majority were girls, as you can see, and only one of them were able to walk unassisted. But Dr. Kosho, in further studies he's done in Japan, reported 2 children who were able to walk unsupported at about 5 or 6 years of age. And I know other unreported children in SOF that walked unsupported at 5, 6, 7 years of age. So certainly not accurate to say that a child will never walk, but of course, walking unassisted is rare. There are more than 30 children, or young people, if you will, with trisomy 18 who are over the age of 10, more than 20 over the age of 20 years that are in the SOFT registry. And there's the web page of SOFT. If you haven't seen it before, I recommend going to the web page. Right now, you'll even find the list of the conferences that are going on this week. Today at 4 o'clock Eastern Time, Dr. Glenn Green from University of Michigan, who's an otolaryngologist, is going to talk about airway evaluation in trisomy 18. That is no charge, but you do have to register. You can go to trisomy.org, find the link to get the Zoom link, and before that you register. There's also a soft around other parts of the world, and I gave you the link here of the UK's because they have a quite good web page as well. So just some of the young people I've known over the years. I've had the privilege to meet many older infants and children and young adults, as Stacy is in this picture. In this picture, she's in her early 20s. Stacy passed away a few years ago at the age of 35, and her parents there are the reigning presidents of SOF still. Young woman there in her early 30s, who I also knew from Utah. This was at a SOF picnic in 2001, and Joey on the left there was from North Carolina. He passed away in the late second decade, and the oldest male with full trisomy 18 that I've known. There's my friend Aaron again, with you can see his cleft lip and then the repair And one of the other young ladies I follow here, I'm going to see her today at noon at our children's hospital. This is Luna when she's about 3. Now she's 5. She's from actually a Caribbean island. And because they weren't able to actually have very much in the way of medical care, no cardiologist, they came on a medical visa and have been able to stay, and Corona allowed them to stay longer. So she's followed by our cardiologist and by our team here. So children with trisomy 13, again, there's only 15 reports of well-characterized individuals over the age of 3, kind of a younger age people pick to write papers. You can see the range. I've known of known through soft a few adults who were 35. While none were able to walk in the medical articles, there have been some reported to walk, including in the one paper by Beatty. But I wanted to point out that I just worked with one of our genetics fellows, Amy Lebedoff, and we have a paper that just appeared in the American Journal of Medical Genetics just 2 months ago, reporting 11 adults with trisomy 13. So I draw your attention to that paper, and it's meant to point out some of their issues and their particular life stories. But through the SOFT and through the associated group called Living with Trisomy 13, we know more than 20 people that are over the age of 10, including this young man is only about 2 in this picture with trisomy 13. And there's Aaron, the boy I showed in the black and white picture earlier, who was in the walker. Here he is as a teenager, and he passed away also from a pneumonia when he was about 15. So let me talk more about developmental outcome. I've been kind of giving you a brief snapshot of developmental skills as we've gone along. This young lady's mother, Ann Barnes, is the curator of our SOFT registry. We do actually have a registry where we keep track of children who have had surgeries and also have been treated for a Wilms tumor, which occurs with increasing frequency in trisomy 18. And Ann is still the curator of that registry. Her daughter, Megan, passed away when she was about 18. So in 1994, Bonnie Beatty, a genetic counselor I worked with, and a few of my colleagues and I reported a paper on developmental outcome in trisomy 18. There's a little bit more published after that, a small series of kids kind of giving you a sense of milestones or neurodevelopmental assessments. But here you can see kind of a list of milestones in both 13 and 18. Smiling, average 4.7 months. Sitting alone, average in 18, 38 months. In 13, 31 months. But we also collected developmental records on the children. We have a smaller number where we got the developmental records than the previous slide. But I draw your attention to the highlighted age group of 3 to 5, the highlighted yellow there, where children with trisomy 18, the chronological age in both 18 and 13 was just under 4 on average, and the developmental age was 7 to 8 months. However, as mentioned earlier, because in this series, none of the children were able to walk, and none of the children, of course, had verbal expression. But as I mentioned earlier, many of their skills were skills that would be in the second year of life. And to a person, they were socially engaging and certainly knew and communicated with their parents. 2 young ladies and their mothers at a soft picnic who lent me their picture. So hope that gives you some flavor for the neurodevelopmental outcome. I think this is clearly this disability would be called profound based on mathematical scores, but all children do develop and actually have many social skills that we've been talking about. So I wanted to spend the last part of the talk, let's see here, probably will only briefly talk about the cardiac surgery part, because I do want to leave time for some questions. But I'm going to spend the last few slides just discussing a little bit more of the controversy, the discourse that's especially been in the medical literature, and point out what I think are some key papers that also are cited on the paper. I realize that, of course, my PowerPoint presentation is available here to be given out, and I don't know if that was something I talked about with Emily and Jamie, but of course I'm hoping you could have the PowerPoint. But 3 papers here I already mentioned, well, the one by McCraw and Perlman, where they polled neonatologists who the majority of which said they wouldn't resuscitate a child in the delivery room. Two other papers that I feel like are quite seminal in this discussion. The one by Kugler in the Hastings Center Bioethics Journal really talked about what are the arguments for intervention in a condition with this degree of disability and these figures about medical complexity, for and against, and they actually go through those arguments quite nicely. But they're picked up on again in the paper by Lorenz and Hardart, who also actually lay out kind of a table of how we might approach working with families and helping them make a decision about, are we going to go have intervention like ventilators or whatever else we might pursue, including even cardiac surgery or not. So I recommend these papers for your perusal. In the McGraw-Perlman paper, I pulled out what I thought were the key issues for our discussion. Questions about who makes the decision. I think in the papers I just cited in the previous slide, kind of the consensus is that in areas where there isn't always a clear answer, sort of the consensus of the bioethicists and even Lorenz in their paper was to have families be a major part and really in the driver's seat about these decisions about intervention, let's say, on the other side, pure comfort care. Obviously, allocation of resources always come up. I'm not going to discuss that in detail, but always important in this discourse. And of course, what always emerges is issues around quality of life entering in the decision and the issue of what actually a child experiences in one where we might be intervening. That's where I mentioned again, this is probably the third time I said that Lorenz and Hardart do a really eloquent job laying out the issues and kind of saying that parents are important in these decision makings, involve them and let them have a major say. But those authors do actually talk about improvements in treatment in recent years, which would include actually over especially the last 12 years or so, the option of cardiac surgery much more than before. So now there's a paper published in 2019, Cooper et al. In the pediatric surgery literature where more than 350 children with trisomy 18 or 13 had cardiac surgery for various lesions. With the disability advocacy, trend of the last several decades and the importance of support groups have all led to kind of a place now where we are compared to before. But I think in the interest of time, I'm not going to discuss the cardiac surgery studies in any detail. I would like to make some sort of closing statements, but I refer you to this slide, to the references that talk about these studies, but I'll just kind of give you in an oversimplistic way without going through the data or the studies, is that the bottom line is that in these cardiac surgery studies, on average, about 85% of children experience the surgery in the PICU and all the rest and go home from the hospital. Some of the studies, like the one by Kosov cited there, give you some sense of long-term where they are, but we don't have a lot of long-term data. In the soft registry that I mentioned, there are 183 children have had cardiac surgery from VSDs, coarctation, palliative operations like pulmonary banding, sometimes even a total repair of tetralogy of Fallot. 41 children with trisomy 13. These are all parent-reported, but full trisomy 18, full trisomy 13. And most of the surgeries we're talking about have been in the last 10 years. One of my patients, at Primary Children's Hospital, had cardiac surgery. You could see her on the left, and also when she's a preteen on the right. And here's my friend Sam, who I'm also going to be seeing at our Children's Hospital in the near future, who's now just over 2, who actually went to the University of Nebraska Omaha Children's and had his surgery. And you can see he still has a trach, but he's actually coming down on his ventilator. He's on home ventilator at home and doing better. So here is the third question. Recognizing I went through that slide rather quickly, but what is the average discharge to home rate in children who have had cardiac surgery in these recent publications with trisomy 18 and 13? 25%, 45%, 65% or 85%. You probably know that in a ventricular septal defect repair, even in Down syndrome or in a child without trisomy 18 and 13, the discharge to home rate is 98%, around 98%, very high. So all of these figures, of course, are less than that. But the answer, as I mentioned on the bottom line of the previous slide, is 85%. So just a few closing comments. It looks like then with that, we'll still have as much as 10 minutes for time for questions or any discussion would like to have. But point your attention to what I had on one of the early slides, that one of the models in care certainly used a lot, I suspect, in your NICUs and your PICUs, as they are around the country, is this appropriate premise of involving families, in this case parents, in a shared decision-making model. And Dr. Andrews here in this paper that came out of an ethics conference that occurred at Denver Children's in 2012, published then in the American Journal of Medical Genetics. I had the fortunate to be part of it. In that paper, goals of care are kind of laid out in a table. There's a checklist of issues that might come into the script, suggested professionals that might participate in care conferences or other discussions with the family, and the resources that families and you might have in this dialogue. So I point your attention to that paper, as well as a number of other papers that have appeared. The editorial that accompanied the JAMA paper that I mentioned earlier, the JAMA paper by Nelson, that also talked about shared decision making. So there's a decent amount in the literature that can give you some guidelines. As Emily mentioned, I was the editor-in-chief of the American Journal of Medical Genetics from 2001 to 2016. And in 2016, I actually organized a special issue on trisomy 18 and 13. So that now, that's been almost 5 years, but I point that issue out for you. 2016 September issue of the American Journal of Medical Genetics, so-called Part C. And here are some of the kids that I've known. Some of are Utah kids, some are from SOFT. So in summary then, the range is about 5 to 12% of children. 12 is the more recent figures. That's kind of a lumped together figure, with trisomy 18 and 13 survive to 1 year of life, with more than the majority of those who survive to 1 year surviving to 5 years of life. So the different take on the survival figures in those recent studies compared to the population studies earlier. Children do have a significant developmental disability, but continue to progress in their milestones and are quite socially connected. And as mentioned, parents should be a part of the decision-making process. And so I point your attention to the reference by Andrews, which I mentioned on the previous slide, and then Hoag's paper in JAMA that accompanied the paper that I mentioned about Ontario, actually talks as well about shared decision-making and palliative care models. And I recently completed the chapter in the book Cassidy and Allenson, which Emily mentioned early on. The 4th edition just came out in print, John Wiley and Son, and I have my chapter there on management. And here's a photo from the Utah SOFT conference that we had a few years ago, with parents all who have, all the kids depicted in this picture have trisomy. And I'll close, and then the references are hopefully available, assuming that you can get the PowerPoint. And I close with a haiku poem that I found when I was at one visit to Japan, when I was visiting Dr. Kosho more than 10 years ago now, that somehow captured some of the experience, if you will, and the emotion around these serious conditions. And I happened to have been there during the time of the cherry blossoms in May. And what Busan, one of the patriarchs of this genre, said was, "The end of spring lingers in the cherry blossoms." I'm going to go back. Maybe Emily can tell me. I want to open up time now for questions. It looks like we have about 8 minutes or so for questions. So or comments, I would greatly welcome them.
Dr. Carey, this is Dr. Keyes. I'm the interim chair here. Thank you for this talk. I've had the opportunity in my career to care for one child with trisomy 13 longitudinally. She died at about in the early 20s, and another child episodically. I'm curious about the survival numbers. When you look at how many of those children have normal hearts, that to me, that's always, and that maybe just a factoid in my head, but the long-term survival, is that associated with a normal heart or not? And how is that, what's the implication then on cardiac surgery for these children?
Right. So the population studies never really tell us that answer in individual situations, as you can imagine. That is, they'll often have in there the frequency of children who have a heart defect, and that, as we mentioned, in trisomy 18 in particular, it's over 90%. In trisomy 13, it's about 80%. Certainly in some of the children that I showed you, and then adults in those pictures, all of them actually that I showed that were older, you could see had ventricular septal defect, but some of them closed. So Stacy, the girl I mentioned, was in her 20s and died at 35. Her VSD closed, and so she never had issues of pulmonary hypertension, which is what, we know 30 years ago was the issue, 40 years ago was the issue in Down syndrome. So certainly in those children that are in that 6% that survived, well, I'd have to go back and pull those case reports of the more than dozen or so, but there probably is children less of a frequency of having the heart defect. But in the cardiac surgery studies, what they showed in previously in Japan, and then what Kosif showed in her paper in Pediatrics, is when comparing them to historical controls, those that they were able to follow out were living past a year of age. So if you looked at the studies and compiled those numbers, you would see that cardiac surgery performed in the first few months or 6 months, in the early Japanese study, 9 months, did confer increased survival to a year of age. So going back to those cardiac studies, and if there's another question, I'm just going to refer back and carry on my addressing your question in more detail, unless there's another question.
John, thank you so much for your talk. I think it's been really interesting to watch the emergence of the internet and social media circles on parents' perspectives on the care of their children. And I wondered if you had any thoughts about seeing changes in parent attitudes based on networking online with other families for their child with rare diseases.
Thank you, Emily. That's a great question. And I'll share my thoughts and my experience. There's a paper in Pediatrics about a year ago, and I'm sorry I don't have the exact citation, but there's ethics rounds in Pediatrics now that Dr. First and others initiated a few years ago. And there's a story in ethics rounds in there, and I don't remember what medical center it came from. It's probably a moot anyway, but they do have a few paragraphs mentioning how the family in that interchange, whose child eventually passed away, even though they wanted intervention. They did have intervention, but things were drawn out for several months. In there, the family mentioned how a lot that they would have learned on internet, and even expressed some pressure from various spokespeople on the internet. And it is my impression now. I worry sometimes, and I even alert families to this, especially in our fetal center, especially afterwards, that while I'm hopefully helping to present them a balanced view, that there will be very outspoken people on the there are several Facebook pages on both trisomy 18 and 13, and sometimes there'll be some who will be louder than others. And I've had some families that told me that they felt some pressure in that direction. So I think and Dr. Lorenz brought it out in their paper as well. So I know from families I've been involved with where we had children with either of the conditions or even other rare syndromes, where there were, in particular, Facebook networks where we are discussed on those networks. I mean, our names are used. We might as well admit that we're going to be in that position. I myself avoid it completely, even though I have Facebook in other situations. I'm barely ever on it anyway. But in that situation, I'm in terms of the ones that exist through the support groups, I'm not on their Facebooks. I think it's important for us, and I think I suspect we'll agree, for us to even alert families to that fact that we have to have this balanced view, and that pressure should not be overriding other aspects. So it's complicated. I appreciate the question. By the way, you made me think of it with that question. I forgot to mention, by the way, in the very beginning, I have it written down in my notes that I want to acknowledge Jamie Lint, that many of you probably know, who originally helped me organize